Welcome to Hope for Med.
Hope for Med.
Hi, everyone. Welcome back to the Hope for Med podcast. I am your host, Dr. JB, and today's featured guest is Dr. Crystal Maxwell. She is a board-certified family medicine physician. She's the founder and CEO of Light Family Wellness, the first direct primary care practice in Indian Land, South Carolina. Welcome to the show.
Thank you so much. I appreciate you having me. It is a joy to be able to share my story. I am coming off of celebrating my 1-year anniversary for my medical practice. We had our ribbon cutting January 29th of last year. And so the 29th, this past Saturday, we were celebrating our first birthday. And it has been an absolute pleasure. In spite of being in the midst of a pandemic, which I was not expecting at the time I was planning to open my practice. But it has been a really, really great year. So I'm excited about having made that transition. I am, as you said, family medicine trained, and I had practiced for 10 years at a community health center right out of residency training. Moved to the South Carolina area and was working for a community health center. For a couple years, I was just a physician there. After a couple years, got introduced into doing some quality things as we were trying to transition into becoming a patient-centered medical home, and really liked having that administrative component to it, of being able to influence what the day-to-day looked like and what the things that my clinicians working with me needed, and how that patient care would look. And so I became the chief medical officer, and I was chief medical officer for 8 years after that, until I decided that I wanted to practice closer to home. I was driving about an hour each way to my community health center, and I wanted to practice closer to home, and I wanted to do something a bit different than the traditional model, which led me to the direct primary care model. Part of me had become kind of, while I was enjoying the administrative aspect, the clinical aspect was kind of draining. I was beginning to experience some burnout with that, because I felt like things that I was dealing with patients, dealing with chronic diseases, having multiple things that needed to be done for them, just could not be managed in a 15, 20 minute on a good day, if somebody no-showed. But that just was not enough and adequate for the primary care that I felt that people were needing, as I was trying to talk with them about changing their diet, increasing exercise, what that needed to look like, how that needs to look like, what kind of sleep you need to be getting in, because you're always tired, but you're always on the go and not stopping. Being able to have those crucial conversations for lifestyle changes, I just couldn't have that. And so as I was trying to decide what my next step would look like with wanting to practice closer and wanting to do my own practice, I decided to do the direct primary care model, talk with a few friends of mine who were doing it, talked to someone locally who was doing a direct primary care in a city over from me, and she became my mentor. And so I was like, yes, this is medicine. Being able to actually get to know your patient again and talk with them about what's going on with them, getting down to the root cause as opposed to just a Band-Aid, and having that unrushed time of not being worried about that you're double booked or triple booked, and that you've got, 15, 20 people waiting behind the schedule. That for me was part of what I saw myself when I decided to become a physician when I was only 14. But that's how I saw myself practicing. I saw myself spending time with people, getting to know them, kind of being part of the family, as in family medicine. But that had been lost in the more traditional practice. And so direct primary care for me was a way to really get back to what I saw myself back when I was 14 doing. So it's been a great year of being able to do that, and we are growing.
Yeah. So, I mean, you shared so much, and we're going to go ahead and go back a little bit, because it has been quite a journey, because you went from deciding to go into medicine at the age of 14, then you went into medicine, and then you went to community practice or community center practice. Then you did leadership, and then you are now in direct primary care. So walk me through what happened at the age of 14, because you mentioned that a couple of times. So what happened that, kind of inspired you to go into medicine?
Yeah. So my grandfather was diagnosed with prostate cancer. It was one of the advanced stage ones, unfortunately, not one of the common ones that's kind of slow growing, but it was an advanced stage. And we pretty rapidly saw him decline and ended up losing him to prostate cancer. But in the process of that, going to the hospitals, and hearing nursing staff come to the house and just listening to conversation. When we were at hospitals, hearing the doctors talk about just different things, I wanted to know what they were talking about and what the words meant, what the terminology meant, what the machines were for, what all the tubes and all of that stuff meant. And so that just really further piqued my interest in science. And so after that, I just began going to different science summer camps and, anything science related. I just started doing that because I was like, yep, I want to be a doctor. This is something science. That's what they say. So let me figure this out. And so it was just really walking through that journey with my family, seeing them still come home and have questions about what the doctor said, and it not being an easy feat to be able to get back and try to get that clarified, was a frustration. And I was, I didn't understand like why it didn't make sense to me. And so, part of my, passion to do it was, well, whenever I become a doctor, I want to make sure all my patients understand. And when they need to clarify something or just check back in, they just call me, they just check back in. And so, that was my idea of what I foresaw of a way to be able to practice. Unfortunately, lo and behold, once I actually began practicing, I learned that it's not quite that easy. When you come to being in a system of medicine, there's so many other things that come into play for that. And so, after just kind of playing the system for 10 years, I was like, well, this still isn't me. And I felt like I was not giving the part of me of why I became a physician in the first place. And so I was like, I have to either discover how I can do that, or honestly, I will have to figure out something else to do because I could not continue in that format because that just was not genuine for me. And so doing direct primary care, as I learned about that, seemed to make sense. And so in the past year, it has absolutely made the more sense of me actually being accessible to my patients and being able to give the way that I thought that I should be able to, even back then.
Okay. So you said, yes, I want to be a doctor. At age of 14, my grandfather was diagnosed with prostate cancer. But you decided family and not oncology or anything like that. What made you decide on family medicine?
Well, that came later. Well, I thought about that at first, just because you can help everybody. But even when I went through training, I thought about cardiology, as I had a lot of family members who had heart disease issues. Even through rotating at one point, I thought I wanted to be a neonatologist. I enjoyed OBGYN. I was like, oh, I can do obstetrical surgery. I was like, oh, I can be a general surgeon. I like surgery. I like procedures. So honestly, even when I went through all of my rotations, I felt like I could do this on pretty much all of them, from psychiatry to being doing nephrology. I ended up feeling like I could do all of them, which brought me back to, well, that's why I thought I wanted to be a doctor for the family anyway, in the first place, because I enjoyed everything. And so it ended up coming back full circle, that I really still want to be that medical liaison between patients so that they understand that kind of that quarterback is what a physician is, of making sure you understand what's going on with your specialist, that you do have that person that you trust and see all the time that you can go back to and say, hey, can you explain this? They are doing this. Or, catching that two different specialists are seeing them and now they're on similar medicines because one specialist don't know that this was started by the other. So really being able to be that person who can guide them through was really what I felt to be my calling. And here I am.
Take care of the whole person.
Take care of the whole person. Yeah, and so, seeing my kids when I was in the previous practice, going from, seeing them when they were little and, then all of a sudden they're hitting that teenage years of, it's really nice. And then being able to coach mom about, them growing up and things like that. So just really being a part of the whole family for me was just really where my passion was.
Yeah, and that's so key because as an emergency medicine physician, I take care of so many patients who come into the emergency department and they'll be like, oh, my cardiologist, is this, and, my nephrologist is this. It's like, well, who's your family doctor? Oh, I don't have a family doctor. And I was like, well, your cardiologist focuses on your heart. Your nephrologist focuses on your kidneys,
Mhm.
but who focuses on you as a whole to make sure that, everything, the medicines that you're on and whatnot are actually okay, for you as a whole. So it's extremely important.
Yes, absolutely. So that has been, the big joy for me is being able to be that person.
Mhm.
And, now that I'm a lot more accessible as opposed to, experiencing, 2 weeks or so before a patient could get in direct primary care. Like today, I was sitting in a meeting and a patient texted me and she had some issues that she had a yeast infection, and I sent her a prescription while I'm sitting in a meeting. And so having that flexibility, because I know her, we've dealt with this before. I know what's going on with her. I don't have to bring her in because it's pretty cut and dry of what's going on with her. I could just take care of her without her having to interrupt her work day and losing hours, having to drive over and do all of that stuff immediately. So it's very nice that my patients have me and accessible to me, and I'm able to guide them. And they know that Dr. Maxwell is going to answer my question. And if she can't figure it out, if she doesn't know, she's going to figure it out and she's going to get back to me. And so being able to have that space and direct primary care to do that makes so much sense for me. And so makes me put a smile on my face going to work every day.
Well, it seems like direct primary care definitely aligns more with your vision of yourself from the age of 14.
Yes.
So let's talk a little bit more about that journey, though, that led you down the path of direct primary care. So, you did family medicine, and then you decided after graduating from residency that you were going to go into the community and community health center. What made you decide to do that?
So since I knew that I wanted to do, I was thinking family medicine from the jump start. So even when I applied to medical school, I was looking at financially, how am I going to pay for this? So one of the options that came up was the National Health Service Corps. And so I applied and became a scholar because I knew I was going to do something. Primary care was what I had planned. And that was a way that either rural medicine, I'm originally from Mississippi, grew up on a farm, 20 plus miles from the nearest hospital. So I knew rural. And then I went to undergrad in Atlanta. And so was able to see urban underserved areas and do volunteer work there. So I knew that either I was going to do rural medicine or I was going to do urban underserved, something in primary care. And so National Health Service was able to, provide me that financial option to get medical school covered. And so that was kind of what kind of led me and kept me towards that primary care, although there are some other things like psych and things like that you can go into to be able to do National Health Service Corps. But I definitely knew for the most part it was going to be something primary care related. So that helped to kind of guide what areas I was going to end up practicing in once I finished, because I was going to have to serve back that time once I finished medical school. And then once I did residency, I got married during residency, met my husband during med school, and he did a specialty training in pharmacy on the areas of internal medicine and cardiology. And so at the time that he was finishing up, I was finishing up residency and he was beginning to look for jobs, it was going to be more difficult for him to find a cardiac pharmacist job than me. And so we pretty much looked at where he would be able to go, with the restriction that it had to be somewhere it didn't snow all the time. Because again, I'm a Mississippi girl. Okay. And I was not trying to have to go to work in the snow all the time, because I'm a physician, so I don't get a pass.
Yeah, exactly. You are essential.
So he found a place in Charlotte, and I found a community health center that was within the National Health Service guidelines for me paying back that time, which is what led me to the community health center that I worked at for 10 years.
Mm-hmm. Yeah, no, you're talking to a Florida girl, so I completely understand.
Yes. I don't mind heat. I am not there for the cold. I'm all ready for April, May to come on.
Right.
So give me some heat. I would rather be hot than cold anytime.
No, yeah, I completely understand.
Yes.
So, one of the things that you mentioned that was very interesting was you said that, you would get 15 to 20 minutes with the patient on a good day if somebody canceled. So can you walk me through, your experiences in terms of trying to really connect with your patients and, be effective in terms of helping them manage their health, and how much time you had allotted to do that?
Yes. So one of the nice things about being on an administrative side was I was able to work on the schedule. And so we initially started out on the standard template of 15-minute schedule, 30-minute for a new patient, 15 for general follow-up, or 30-minute for a physical exam. One of the things that we did end up incorporating was doing a 20-minute schedule to try to improve some of that time that the clinicians had with the patients, but still trying to, of course, maximize how many patients we were able to accommodate each day. And so the 20-minute schedule did help, but even still, there are numerous quality documentation things that you have to do to satisfy insurance companies, some of which is important for patients, but not necessarily in terms of the timing in which they need to be done. Doesn't coincide to when insurance companies may want to see that done. But the documentation for doing quality stuff, having your nurses try to do as many things as they could on the front end, such as getting an A1C before you walk into the room with the patient, or getting their foot exam done if they were due a diabetic foot exam. Having them do all of those things for pre-visit to give you more time was a way to help improve that. But even still, there's only so much that the nurse can do, because there's still a lot that has to be documented and done with the patient. And so if you're talking about someone who's diabetic, high blood pressure, have high cholesterol, have COPD, may have anxiety and depression. I mean, you're already looking at 6 or 7 different things that you can actually take any one of those things and to actually go back through and understand what's going on with them at home, to see what things may be impacting their ability to be under control. There's no way that you can have those crucial conversations with all of those chronic conditions in 15 minutes or 20 minutes. And so, all of those things, it makes it very difficult to really get down to some of the foundational things that are impacting people at home. That, of course, in big systems, we try to have social workers come in or have other staff and nursing staff and behavioral health staff to help to kind of take some of those things off. But for a lot of people, they want to have those discussions with their doctor. And there are things that your doctor will pick up on that even, as great as social workers are, behavioral therapists are, and the nursing staff are, there's still certain things that only the doctor will be able to pick up on and can really address, because it's the doctor that the patient is coming to see. And so they will withhold information until they get to you. And then you have to go back and try to figure out how to pull all of that together with the other priorities that your system, organization, insurance company is asking for you to do as well. And so sometimes, unfortunately, the priority that the patient has that they really deem important to be discussed is not discussed. And so some of those things are lost in translation, and you never get to really get down to some of that foundation stuff that they're dealing with. And one of the great examples I have a lady was taking care of at least 9 years in my previous practice, came with me to my new practice. I still had a full 1 hour new patient visit with her, even though I had known her for 9 years. And out of that visit, there were things that I never knew about her that genuinely impacted her depression and anxiety, that it hurt me to know that she had been carrying so much of that that's impacting her depression and anxiety. And I was never able to have that conversation and get down to that level of discussion with her. And once we were able to talk about those things and begin putting in a plan to address those external things that's going on in her life, her depression began to get better.
Wow.
But I could never have that conversation in 15 minutes because we had so many other things that were quote unquote priority to be discussed or the box checked. So it definitely makes a difference when a patient is able to open up to their doctor and have those crucial conversations and feel like it's not rushed and it's not a burden. And I know that somebody else is waiting. So I'll just wait till next time, because next time for some people never come.
That's right. That's right. Wow. Wow. What a powerful example. 9 years knowing this patient, 9 years of seeing this patient, taking care of this patient, trying to manage their medical conditions. And still, there was so much that you had no idea about.
Yeah. Yeah.
Wow.
Yeah.
And just taking that extra time to discover and connect with that, then you're able to actually have a profound effect on their life, something that you've been working on in terms of like their anxiety and depression for 9 years.
For 9 years. Yeah.
Wow.
Yeah.
Wow.
Yeah. So time with your physician makes a difference. And I know that, there's so many things of saying, we can, like I said, there is place for a team and teams are great, but, there's nothing like that doctor-physician relationship, that physician and patient relationship that patients really take to heart. And so I'm hoping as we go forward in the future and there are more physicians who are doing direct primary care, that will be heard, because that's what I hear from a lot of other physicians who are doing direct primary care, is that is what their patients are saying, that they have the time, they have the space to be able to have those conversations that, go into more of the lifestyle and the lifestyle changing things that can help to impact their lives.
So you mentioned in the beginning that you had experienced symptoms of burnout. Can you talk a little bit more about what you had experienced and why?
Yes. So with burnout, a lot of that came with trying to manage that work-life balance. On one hand, I was a physician seeing patients clinically, so I had those responsibilities. On the other hand, I was an administrator as a chief medical officer, so responsible to the board of directors, the CEO, all of the administrative operation team, and then also to the clinicians that I was advocating for and representing. There's so many complexities to trying to maneuver all of those things in one. And then I'm a wife, I'm a mom, I'm a daughter, I'm a friend, I'm a cousin, I'm a sister, so there's so many different facets. I volunteer at church. I volunteer within the community. So trying to find balance in between all of those things just became it became a lot to do. And so I did have to, and my daughter was growing older. I did have to make some crucial decisions about what my life was going to look like. So even prior to making the decision to leave that job and practice closer to home, there were times that I had to say, okay, my daughter is at her soccer game. I am not going to answer my phone because I am at my daughter's soccer game. But, there were times that, if a clinician called me because there was something urgent going on with them, or there was something, administratively going on that needed to be addressed, I was just pretty much, I'm here to support you. And what can I do? But I had to develop some barriers for myself and say, well, I have to stop and I have to give my attention to my family as well, because work is work, but home is a job too. I have to definitely make sure that I'm dedicating that time to supporting my daughter, supporting my husband. So making some barriers to stop there, and making sure that I'm delegating to other people. But that was hard to do because it was, I want it done a certain way.
Yeah.
And
Nobody
I know
can do
how
better
I
than
will
you.
do it.
Yeah.
And so, but I had to start making some decisions about, okay, you still want to train other people to be able to do some of the things to support you in doing. And it was just, I had to make those crucial decisions of what was most important, with understanding that, of course, sometimes family is going to take precedent and I'm just going to have to say no to work. Sometimes work is going to take precedent because this is really important. But you have to make sure that you're looking at that all of your time is not on this one thing, especially for work, because at the end of the day, it is your family that's going to be there when that job is not, because, you could die today and they're going to find a replacement. But they won't find another mom. They won't find husband could find another wife, but not me, of course. But, there's nobody to replace you in that family unit.
Okay.
And so those were lessons learned along the way that I'm taking with me now that I'm in my practice. So even though I'm independent and it's only me, I tell my patients, if there's something minor, I'm at home with my family. I'm enjoying my family. I'm not going to respond to your text if it's something minor. If it's after hours, I will respond to you during, business hours the next day. And so that's a very important conversation I have, on the front end when someone's enrolling in my practice, because I don't want to go back to that. Work, this is work. And again, I am, either the success of my job is really dependent on me now that I'm an entrepreneur, but I still have to remind myself that I'm not in this alone, and I will burn out on even something that I love with doing my practice if I don't set priorities and I don't set those barriers.
So it sounds like, what you're saying is boundaries and the importance of setting boundaries and being very clear about your boundaries to prevent you from going down the path of experiencing symptoms of burnout.
Yes. And so setting those boundaries, and also knowing that, even when things become redundant in life, you have to still kind of look at what else can I do to fill in my day. So even though I enjoy clinical medicine to the fullest, I still enjoy doing a lot of things with the community. So I'm still looking at opportunities that I can do non-clinical things administratively, like consulting with community health centers, to help them through their processes, so that I still have another side of income, that I'm still not strictly dependent on just that clinical income that's coming in. Yep. So that, I can do the consulting things when my daughter's down for bed or my husband's doing a business meeting, and it's after hours, I'm at home. So I can do a little bit of consulting then. So I'm trying to be very intentional about the way that I handle my time and give out my time, so that I can still keep variety, and not burn out on, all of the things as I did before.
Mm-hmm. Mm-hmm. And so with this direct primary care that we've talked about, when did you get introduced to this concept?
Actually early on, one of my best friends that I went to residency with, she started her practice probably a few years after we finished residency. And I was like, go you, I'm employed. So I knew about it, but at that time, it just really wasn't for me. One, I was still fulfilling my 4 years doing my National Health Service time back. But two, it was, I'm okay with being employed right now. I'm especially once I became administrative and, given some voice, doing a lot of things for people who otherwise would not have healthcare because they didn't have insurance or they were underinsured. So for me, I was, doing things that I really enjoyed and still being able to give back by practicing at the community health center. So it was more of a support thing in life. like, okay, well, that's a nice idea, but you have to do it all yourself, and you're the only one on call, and it's just you. I don't want to do that. At least now it's me and all of the other clinicians who are working. We take rotation on call, and all of that, strain is not solely on me. But as I progressed and began to get to know another friend who started doing some concierge, and attending American Academy of Family Physician conferences, where I was hearing more family physicians talk about doing direct primary care. I had another medical school classmate who opened her own direct primary care, and ran into her at a conference at a time that I was kind of like, I don't know what next steps are. I'm kind of content, but you never know. But having that conversation with her was like, well, maybe I should think about what, I've been, it was probably about 7 or 8 years at that point. Maybe I should think about next step. Do I want to continue doing an hour drive, for the next 10 years of my life? At that time I was content, but I didn't know, but I just knew it was something that was growing. Yeah. In terms of family physicians wanting to kind of take back ownership and be more available for their patients. And so just as I kind of was going through that lull of, maybe this is something to explore, things just began happening, of all smaller things of running into people all at the right times, just began happening. And so timing is everything. So I do believe that it was my time to begin exploring and hearing, just because once I started hearing it, there were just different people that were starting to kind of plant seeds, or I'm being exposed to this, or hearing a lecture or somebody talk about it. So there was just, I think it was just a very predestined thing for me just to begin to be exposed to it, and my eyes being open to, oh, well, maybe I do need to go back and talk to all these people and investigate a little bit more. As I'm beginning to make that transition, my daughter was doing dance, soccer, and swim all at the same time at one point in our lives. And so I knew that I wanted to be able to be more available for her, to be able to see her competitions and support her in the things that she was doing. So it became well, let me investigate and research this more fully, because I do want to be closer to her. But I don't want to go back into a more traditional model when I do it. I do want to have a more flexibility of going to her school and doing readings. And if there is a school field trip that, I can jump on and say, hey, I can volunteer and do that too. So I think it was more of a timing thing that just kind of began leading me towards saying, let me be a little more open and begin doing my own investigations into it.
And so with your setup, is this like a subscription, or how does it work? Do you accept insurance? Walk me through direct primary care.
So direct primary care is membership based, kind of like you can say subscription. It's kind of one good analogy is kind of, if you say having a gym membership. So you have a gym membership, but it's like having your personal trainer included in your gym membership, your personal trainer being your physician. And so that gives you access, paying that membership fee to your physician. And so that you can access them directly. All of my members have my phone number, my email address, so they can either text, call, or email me directly, as opposed to going through the lavish phone tree with other people, or having to press all the different buttons to get to this department. You actually send a text to me and I can respond directly to you. So it provides a lot more flexibility and ease of access in that regard. Your membership fee includes all of your visits with me for primary care services. So whether that's an in-office person or a video visit or a phone visit. I do a lot of text visits now because people are technologically savvy. You can text some things that are pretty straightforward. And so all of that's included in your membership fee. And with the growing number of direct primary care physicians that are around, I'm not the first. This has been over 20 years of people who have done this. And there is a direct primary care alliance who have put together, working with vendors and labs, pharmaceutical companies, to help facilitate that process of what physicians would need to get their supplies, to provide easier access to labs more affordably, to provide access for medications for those who are in states where physicians can dispense medications. So there have been a lot of physicians ahead of me who put a lot of those things in place so that I can provide all of those services to my members, particularly with the labs, even my insurance patients, when I go through them about how much it would cost to do a cash pay option for their labs. The vast majority of them say, unless they're Medicare or Medicaid, say, I want to pay the cash pay option because I know my deductible, my co-insurance with this is going to be way more than what you're quoting me. To do those labs. And I'm not going to be surprise billed. I know how much it costs now, as opposed to I get it done and, 30 days later, I'm like, oh gosh, that's all my insurance paid on this. And so you avoid all of that. And so, every direct primary care practice is going to have a few different nuances in the way that they set up in terms of what procedures may be included, and things like that. But just in general, it's just kind of the subscription based, membership based, paying a monthly fee to cover your access to your physician, and that covers your overhead. That differentiates you from concierge in that a lot of concierge practices also bill insurance. Direct primary care, if you're pure direct primary care, you don't bill insurance. There are some hybrid models that choose not to opt out of Medicare. And so they may be Medicare. They may have their Medicare population and still bill Medicare for those members. But for those who are pure direct primary care, they're not billing any insurances at all.
Wow, that's such an interesting concept. Do you find that patients will still come to you even if they have insurance, or do you find that there's some hindrance?
It's a growing thing. I'll tell you, 90% of my patients have insurance, over 90%.
But they still pay out of pocket?
And they're paying the monthly membership fee. For them, it's the access. It's the knowing that it's my doctor who's going to take care of me when it needs to be done. I don't have to sit and wait in a waiting room for 30 minutes to an hour because I know she's going to see me at my time.
And one of the things that you mentioned in the beginning is I don't have to wait 3 weeks or a month to get that follow-up. Like I can actually get in touch with my doctor and see them pretty quickly.
Exactly. And when there's something going on, there's not that fear of, I don't want to pay my copay today if it's something that's not big and I don't know if it's big. And so for those people who delay and wait and it is big and they should have, they should have checked in, but they were trying to, avoid the copay because they weren't sure if it was necessary. There's none of that. Because your monthly membership fee is your monthly membership fee. I'm not going to charge anything above that. If I have to talk to you, every day this week, it is your membership fee. And so you don't have to stress or worry or try to, cut costs because you don't want to go to the doctor unnecessarily because you're not going to pay anything extra. I am your Dr. Google. You don't have to go down that rabbit hole of what Google may tell you may be going on with you and you think you're dying. I can help filter through some of the information that's on there and actually lead you to, what is evidence-based, what is scientifically sound, and what is just somebody putting it up because that was their experience. That may be their experience, but that may not be scientific. And so I'm able to, with doing the membership base, we can put all of that aside. Even with my diabetic patients, my ones who are uncontrolled, we can be very intensive and not worry about if I need to follow up with you the next day over the same thing about which, what insurance is going to cover this because it's the same diagnosis and I need to bill this 2 days in a row. I don't have to worry about that. I don't have to worry about, well, this is your Medicare wellness exam. And if I talk to you about any other thing that could be diagnostic, you're going to get a whole other bill, even though you think you have a free visit today. So we have to talk about that on a different day. We don't have to worry about that. Whatever is going on with you, I can address that. Or, I see you this morning and I say, oh, yep, yes, you have a UTI. Let me send you in some antibiotics. And then you call back at 3:00 in the afternoon because you stubbed your toe and now you got a cut. And, what do I do about my cut? Well, a practice that's billing insurance can only bill one of those, even though it's two separate things. They can only bill one visit that day. And so now you have to your practice has to decide which of those are they going to bill and which one are they not going to be paid for, which is, you can only bill one facility can bill one charge a day.
Even if the patient has separate,
you can do one claim. You can only do one claim that your insurance will pay for, unless there's something that's changed in the last few months. I doubt it, but you can only do one claim. And so, it used to be that if you were seeing someone in a doctor's office and you sent them to the ER, your doctor's visit may not get paid for because they're only making one claim. They were only going to pay one provider that day. Now I believe they have changed that to where they will do both. But again, it's playing a game to be paid for services that you render. Why do we as physicians have to coerce people to pay us for services rendered? We had something happen with our oven, and we had an electrician to come out and take a look, and we unplugged the oven, and we probably should have plugged it back up before we called because it was over the weekend. And when he plugged it back up, it was working again. And he was like, well, it's still $119.
That's true. He came.
And he didn't do anything. But yet in the medicine world, that same concept is, it's your time, but you didn't do anything. And so, or you have to convince or document and do all of these elaborate things to try to get reimbursed for what you've done for a patient. And so even though it may turn out to be nothing, the insurmountable years that you have gone to school, the hours that you have paid in going through school and being able to diagnose and acknowledge that, yes, that is something simple. Yes, it may seem simple now, but it wasn't simple for me to get the knowledge and all the time and investment that I can now know that is simple. So it's very frustrating with dealing with those kind of things in terms of payment to provide care for people. Direct primary care removes that by just doing membership based. It doesn't matter. You can have 5 things today. We're going to talk about your 5 things. You can have 3 things today. You can call me back after you leave. I'm still going to be able to take care of you because I don't have to play games to get paid to take care of you. So to cover my overhead, because again, at the end of the day, most physicians are doing this because we have a genuine heart and interest and passion to take care of people. But we do have to have dollars to be able to keep the doors open and pay the staff and, all of those things and take care of our families. So, exactly. It's just a necessary thing that we have to do, but we should not have to fight tooth and nail to make that process happen.
I'm sure some people could be concerned that, well, if I have a patient who has full access to me at any point in time that they want, that like this patient, will utilize that and, be at my office 365 days a year, maybe 2 or 3 times a day. Have you come across that or have you heard any things like that?
So that was a concern. And that was why I told my friend when she was first doing hers, you can have it. I got a whole crew of people who can rotate it with. But when I really thought about it, even after practicing 10 years, and I thought about how many people called after hours that were my patients, not someone I'm covering for, but that were actually my patients, it really wasn't that significant. And it wasn't that significant because the level of care I provided and how I educated them about what needs to happen after hours versus what can happen when you get, of contacting me the next day. And so that onboarding process is very important when I'm talking to my members and, we're going through the patient agreement about what my expectations are and what I will respond to. Do I have some who utilize that a lot more than others? I do. But I started making boundaries for myself too, of saying, looking at that message, it's not important. I'll respond tomorrow. The pharmacy is closed. You forgot about you doing your refill. I'll take care of it tomorrow. Your emergency, and I remind you, please give me time, to do your refill. Don't wait until you're bottled out. Let me know, because you know that as soon as I do know, I'm going to take care of it, provided it is during office hours. So I have those conversations. I've not had anybody who has completely abused it, or when I reminded them of, hey, I know that you did this after hours, but can you, keep, do this during business hours? They're generally respectful. One, they have a stake in it because they're paying a membership. And so they know that this is not concierge. I make that clear. My fees are not concierge level fees at all. And so if that is the higher level of care that they want, then they would want to go and find a concierge. So, there's a way to have that. But, when people call after hours or address me after hours, for the most part, it's usually something that I would want to know about anyway. Because I don't want them to have to go to the urgent care unnecessarily and wait, because they don't know them, and they, for a lot of the things that I could just handle it myself. And so I'm able to do that. But I know that it is that fear, but generally the people who tend to do the membership, they're going to be people who respect you, but you do have to do that education onboarding and be willing to say if someone is overutilizing, have your systems and policies built up of how you discharge someone from your practice. Because if it is not a good fit for you and taking care of them because they are, doing more than what you feel that you can give them, then as long as you have your policies, procedures of how to discharge someone in place, then you're able to, remove that patient from your practice and, and move on.
So, you mentioned about your experience of burnout as a clinician taking care of patients. Did you experience symptoms of burnout when you were in leadership?
Well, it all goes together, because I was still seeing patient and administration at the same time. So I was never full-time administrator. So I always did both. I always did both. So when I first started the first 2 years, I was clinical only. And then when I became medical director, then I still saw patients, and did administration. So I always had to do both.
So did they decrease the amount of time you had to spend with patients, or they just added on administrative roles in addition to a lot of time you're supposed to take care of patients?
It was a progression. When I first started, I had an afternoon of admin time. And then as they asked me to do more duties, I had to speak up and say, okay, I'm going to need more admin time than this. And so the time was increased to balance more.
If you hadn't spoken up, sorry to interrupt you, if you hadn't spoken up, what would have happened?
That's a great question. I don't know. I believe they did recognize that I was going to need more time, but I did have to advocate for more than what was being offered. So as with any position that you're in, assess your time, assess what you're doing after hours, because it all matters, and speak up and advocate for yourself. Or, you do have to, be willing to say, well, I can't add that on. We can delegate that to XYZ, or I can't do it. But I mean, it does take a little bit of motivating yourself to speak up sometimes, because you want to do it and you want to get it because patients are at stake, and your clinicians that you're working for are at stake. But you still have to look at yourself and say you are only one person. And it can't all fall on you, and there has to be other people to support you in doing it.
Mhm. Knowing when to say no.
Knowing when to say no
Mhm.
is important.
Mhm. That's right. So, now that you are doing your own thing, you have your direct primary care practice, it really sounds to me from this conversation that you are actually incorporating a lot of the lessons that you learned through your prior experience to hopefully prevent you from getting burnt out from this new venture.
Yes, I am, and it's still a learning experience. I feel like I'm a workaholic at nature. It is still difficult to turn the off button off for work a lot of times, and so it is a constant reminder to myself that hey, you've done enough for today. You've done enough. I still have to have that conversation with myself and remind myself of that. And I had a conversation last week with my husband about I was asked to do something for my sorority, and I told them no, and I said, "Honey, you'll be so surprised. You would be so proud of me because I was asked to do something else, and I said no." And he was like, "Where is my wife? Who are you?" And I was like, "I'm learning better still, and it's always an ongoing thing, especially as an entrepreneur. It's always going to be an ongoing thing of learning how to say no because you do want to do so many things. You do want your business to be successful, especially if I'm in a small community, so I want to be a part of the community and help to support the things that are going on in the community. But I have to remind myself I'm still only one person. And if I spread myself too thin now, I'm not going to be able to keep up the pace. And then it's going to, something's going to happen down the road. So let's prevent that from happening now. And, they'll find somebody else. I promise.
They will. They will, and really always keep an eye on self-care. But, learning how to set boundaries, learning how to say no, those are difficult things because that's not something that we're trained to do when we're going through our training to become healthcare professionals.
Yeah, it's not. It's not. And I feel, even especially being a woman, we as women tend to be caretakers of everybody. And that goes from, your family to your work. That's just kind of, I feel like it's just an ingrained thing in us that we are caretakers and we are doers and doers and doers. But the doer has to be taken care of or otherwise she can't do. And so we just have to be more conscious and more aware that we have to take care of ourselves so that we can continue doing that beautiful purpose we were put on this earth to do. Otherwise, we're not going to be around to do it for as long as we possibly could have.
Mhm. So with that being said, if my listener wanted to learn more about you and your direct primary care, how can they get in touch with you?
I can be found on my website is www.lightfamilywellness.com. I'm also on Facebook and Instagram at Light Family Wellness. I also have another Facebook page, Dr. Crystal Maxwell. So I'm a lot on social media, do a lot of posting there. But those are the ways that you can find me. And I do love responding to messages. So people who send me messages on Facebook, you are more than welcome to direct message me to get more information as well.
All right, perfect. And so in closing, do you have any last pearls of wisdom for my listener?
Absolutely. One, don't be afraid to step outside the box, even though it may seem overwhelming to do. If there's something that is your passion and you need to step away from something that's kind of burning you out, don't be afraid to do that. Find some mentors. Find people who are like-minded like you, who are doing something similar. It may not be the exact same thing, but find that support team to give you more information. And as you're going along and doing that beautiful thing that you are creating and putting in place, don't lose yourself. Make sure to take time out for you. Make sure to take time out for your family, because at the end of the day, it's your family that is mostly depending on you and is going to be there when nobody else will be.
This is hope for med, new day for med, for us, by us, and just for us. This is hope for med.